Hi everyone, my name is Iman Ahmed and I'm presenting to you Beyond the Numbers, which is a retrospective study. The kind of background to the study is Norman Regional roughly a year ago and started implementing a protocol for all patients who come into the emergency room with an intracranial hemorrhage and high blood pressure. And as a result, the goal of this protocol in was to standardize care in terms of getting the medication to the patient in an orderly fashion, and also to make sure that after the medication has been administered, the required follow-up is also on time or in a timely manner. And as a result, there are no variations in the way that uh, the blood pressure is being managed until it has reached the point to where the blood pressure isn't considered high anymore or hypertensive. And so as a result, we want to go back, like when coming up with the study, we wanted to understand what care actually looked like before that protocol existed. And so we wanted to establish a real baseline and eventually use this data to compare it against post protocol data or post implementation of that protocol. So, as a lot of you know, intracranial hemorrhage is a serious neurological emergency that requires patients to lower their blood pressure within a timely manner, and our target blood pressure range to for it to be considered a timely manner was once the patient had reached a systolic of 150 to 130. And the big question we're asking here is, in the absence of standardization and in the absence of protocol of sterilization, how well are we actually hitting our target, and did the timing of the treatment make a difference? So in our methods, we conducted a chart review, um, including adult patients who presented to Norman Regional Emergency Room between May 2024 and May 2025 and had a radiologically confirmed intracranial hemorrhage and an initial systolic blood pressure above 140. And so we had quite a few exclusions, and to touch over them a little bit. Some of them did not have a systolic blood pressure of 140 that had a bit less. And so we exclude those patients out of the study. One had incomplete data for their blood pressure. We also excluded one extreme outlier that would have whose patient's blood pressure was too high to record it. And so we kept that patient in other parts of the data set when appropriate, but there are other parts where we were not able to keep them, and I'll specify when. And then we excluded a couple of patients who were on complex care meds or who had expired within, I want to say roughly 24 hours, between 2 to 24 hours after medication had been administered. And all of our statistical analysis had been done via Excel, and we used descriptive statistics. So that being said, our results. So if we start with our pie chart over here, we want to show the distribution of how quickly patients received antihypertensive treatment after meeting our blood pressure criteria. So above a systolic of 140. And so roughly two-thirds received medication within an hour. And then the remaining 35% who had to wait longer than an hour were more at risk for complications from prolonged hypertension. And so even before the protocol, we had quite a few patients who were under the 1 hour mark, but the portion that weren't, those patients, there's still a meaningful group. If that makes sense. So even though we had two-thirds be in that time frame, we do want to lower that some. And so in figure two, we have our bar chart, which shows time to blood pressure control after treatment. And so this bar chart we wanted to represent how long it took for blood pressure to actually be controlled after medication was given. And in a sample of 37 patients, the majority reached their target blood pressure in that 31 to 60-minute window, but about 11 patients took longer than 60 minutes. So even after receiving the medication, achieving blood pressure control within an hour wasn't guaranteed. And so we were going to move on to figure three, which is our box plot. And this box plot breaks down the time to blood pressure control by how high the patient's initial systolic blood pressure was. And we grouped them into a couple ranges like 160, 180, 180 to 200, and then above 200. And you might expect that patients who have a higher systolic would take longer to get under control, or their blood pressure to get under control. But visually and statistically, that's not what we found. In fact, there, we go further into this with an ANOVA table, and it confirms our kind of thought, which is that there was no statistical significance between time to blood pressure control across the initial severity of groups. So once the medication had been initiated or had been administered, the starting blood pressure or the systolic blood pressure uh, did not meaningfully predict how long it was going to take. So whether somebody had a 180 systolic versus a 160, as long as they received the medication to reduce their blood pressure, um, the person with the 180 systolic did not have a harder time getting the blood pressure controlled. And so in our residual plot here, kind of also confirms that. Um, with this residual plot, we are trying to find or trying to look at whether giving medication faster led to faster blood pressure control, um, which would also be an intuitive guess. But in the residual plot shown, uh, we it's our data points are scattered around the regression line, and so there's no clear pattern, and then there's no clear pattern with our residual plot, meaning there's not correlation between whether giving faster medications leads to faster, or giving medication faster leads to faster blood pressure control. And then we also did a line plot over here, and that line fit kind of that this line fit plot also confirms our assumption that there's no meaningful relationship between uh whether medication administration alone did not indicate or predict faster blood pressure control. And so the way we interpret this data is that while time to blood pressure control is extremely important, uh, it takes more than administering the antihypertensive medication. It takes standardization in either bedside care or making sure the, the titration of the medication is consistent, and any other delays may or they do contribute to the variability in care. And it's key to note that there are two outlier data points here that we excluded in this residual plot because they had an unusually long time uh from medication administered to blood pressure control. And so, and when I say unusually long time, I'm talking about longer than a day. And so that's why we excluded them. And so what we come to make of our results is that our pre-protocol data kind of tells us that timing alone is not the primary driver of blood pressure control, and the more likely contributors to delay uh, blood pressure control were things like inconsistent bedside reassessment or variability in clinical workflows after medication is given, and overall a lack of standardization of care. And that's exactly why the gap of the protocol. That's what the protocol is for. Sorry, that's what the protocol is for. It's to fill that gap of lack of standardization. And so the main limitation that I want to talk about here is our sample size is quite small, and so um uh while we did want to look further, this is kind of what we were given, and um this the also yeah, this is kind of what we were given, and so the best thing I can say is with that is that we did the best with what we could, but it's still a pretty good start to see how pre-protocol intracranial hemorrhage care is, like what's the current standard of care, and how can the or how has the protocol fixed that? And that's what the post-protocol intracranial hemorrhage data would be looking at if we had it. But thank you so much for letting me present. Hope you have a wonderful day.